the conference. The theme of this discussion, universal access to health, requirements for achieving this goal. It's going to be chaired by Dr. Edward Greene, and the members of the panel, Ms. Claudette Francis, representing civil society and non-governmental organizations, Dr. Amalia Del Reigo of PAHO, and Dr. Anton Cumberbatch of the HEU. I now invite Dr. Edward Greene as chair to take over.
We are trying to engage you in a discussion on universal access and the issues related to equity and management of our development process. But before I start, I want to tell you how we will organize. Here on the panel, we will each speak for 5 minutes and introductory remarks on the theme. And then we will, based on those introductory remarks, we will discuss about 2, 3, or 4, depending on how we go, issues among the panel. We expect the panel will not necessarily agree on those issues, on elements of the issues. And then after that, we will throw the floor open for your engagement. And before we wrap up, we will then come back to the panelists for a 2-minute summary soundbite. Now, we are going to try to be, I will see, and you will be able to judge if as manager, I could manage this process with the stated outcomes that we have. But I want just to acknowledge one person in the room who was not acknowledged this morning. He's new here, and he's doing a tremendous job in coordinating the AIDS response in the region, or helping us to do so. He is just here. Yes, Dr. Ben Ali from UNAIDS. He is the acting director, and I wanted you to know. Now, I want you to know that we have to put a context to what we are doing today. And that context was so ably explained by Dr. Etienne this morning, but I want to restate it here. One is that we are operating in the context of a movement of managing health and development based on certain mandates in the the Sustainable Development Goals, which were passed at the UN last week. 17 goals, 169 targets. I wouldn't go into them except to say that with respect to the goal that really is of interest to this discussion is Goal 3. And Goal 3 states that we must aim at ensuring healthy lives and promoting well-being for all at all ages. But critical to that is the targets that we must achieve. And one of the targets, and I read it because it's important to the debate that we will have this morning: achieve universal health coverage, including financial risk protection, access to quality, essential health care services, safe access to safe water, effective quality and affordable essential medicines and vaccines for all. So, in other words, health coverage, universal health coverage, includes, according to this, access to quality, essential health care services. Now, when we talk about, therefore, universal health coverage as an overall umbrella in the Sustainable Development Goals, it's important for us to recognize, I believe, that we have to decide whether universal health care is something intrinsic in itself, or if it depends on something else, or if it is measurable by other things. And I think the discussion that we will have today would have to clarify that. Because really when I look at the literature, and in particular I go to the Lancet Commission, the Lancet Commission argues that universal health care is really not only about access, but it is about financial protection and the value of health for its own sake. And therefore, universal health coverage is the goal that all people obtain if they have access to health services, if they don't have financial hardship as a result of access to health services, or if they don't have hardship because of out-of-pocket payments. And I believe that when we discuss this issue today, we really have to ask ourselves some questions. The question is, are access to health and universal health care the same thing, two different things, or interrelated? What can the region do to facilitate access to comprehensive health services? Is access to health a human right? Is the region moving in that direction? What alliances are necessary if we are to move in the direction of health as a human right? In other words, what are the challenges we have in the region with respect to the cost of medicines and other health technologies? What are those burdens? How can we relieve them? How can we achieve equity? How can we really in the Caribbean make a difference so that by 2030 we would achieve this goal within sustainable development called universal access to health care? Now, we have very esteemed colleagues, and I have just used up my 5 minutes. What we want to do is to have intervention by first Dr. Amalia Del Reigo from Health System Services. I never get it right within PAHO, but she is one of the leading lights and really a present and future leader in achieving 2030 goals. We have next to her Claudette Francis, whom most of you know, and she is one of the major resource persons in our development response. She's a psychologist and a consultant. And my esteemed colleague, Anton Cumberbatch, who is a senior fellow within the Health Economics Unit. You call it something else, the Center for Health Economics. But sorry, you weren't there, Carl, when I was introducing. And if you give me exactly half a minute, Professor Elsie Lafranc, with whom we all worked, and who was a co-author of a study, the Caribbean Health Study, Moving Towards Equity, which was done in 1996, before some of you were born. But it was to be presented to the World Bank. And I had to speak to her this morning, and I told her what we were doing on this panel, because she's an expert, and I wanted to know if she had anything else. And she said, well, you're doing that again? Can you remember when we were doing the study, we received a note, a scholarly note from then Dr. Carl Theodore. That was 1996. And in it, he made the case for universal access and universal health coverage. So we're still doing that? And I said, yes. She said to tell you hello, and we locked that side. So I want you to know that we are in a recurrent team, and I now hand over first to Amalia, then to Claudette, and then to Anton.
Well, thank you, and allow me to feel at home. It's really great to be here, back in Trinidad after 3.5 years that I have left. I think it will be very difficult for me to capture in 5 minutes the eloquent speech of my director. But nevertheless, I think I would like to make a couple of points. One, for the member states of the Pan American Health Organization, there is a difference between universal health coverage and universal access to health. And the important difference is that in the concept of universal access to health, member states consider that it is important to really include the efforts to address the social determinants of health. So in other words, it is not enough, even if we will have sufficient organizational settings and financing for health care, it's not going to be enough to really provide equity and health for all if we don't address the social determinants of health. And the Health Authority and the Ministries of Health have a key role to play in advocating, in influencing other sectors for the realization of universal access to health. So in that concept, it is very clear, and we have made the distinction in the strategy. The second element is the strategy really is nothing new. When we look at what the strategy core values and vision is, we are not, and it was clear to the member states of this region that the vision about health for all, it was not born today. This was born a long time ago, and what is new or different is that we have really gone through many years of interventions, of reforms, of efforts in terms of the strengthening of the health systems and other actions to work toward that direction, and that a lot of things have changed. The health challenges have changed. The health technologies have changed. The economies have changed. The countries have really accumulated experience. Some of them, lessons learned about not only what can work, but also what does not work. And so in this context, we look at the universal access to health and universal health coverage that I was sharing with Anton, that we are now, the short version of that, we are calling that universal health in our communication strategy because it's easier, it's closer to people. Really what the strategy does is to identify, based on all of the evidence and all of the experiences in this region, specific conditions, interventions that have been considered sine qua non if we want to make another important advance toward universal health. And then, therefore, that I think is important. Core to that is the strategy core values. And the core value, central value is the right to health. The strategy is anchored in the value and understanding that health is a fundamental human right. And that also, along with that, the other related values are equity and solidarity. 1 minute. So that is important. And the last element is, yes, we have specific interventions that can be done to move toward universal health, and countries can really and have the possibilities to do that. All countries. It will require political will, but also specific changes in the way we manage, we organize health systems, and we ensure another important element, which is the engagement and the empowerment of individuals and communities to really join forces toward that important goal. For the rest and the specifics, I will wait for the questions and the debate.
Thank you very much.
Thank you.
I'm sitting among friends and colleagues, probably because there is a perception that I cause sufficient controversy and that it would cause you to be engaged. You can't hear me?
No.
Now you can. You know, I have this soft, scintillating voice. All of last night and in preparing to be part of this panel, I kept saying, everybody would say the things I want to say, and it happened last night. It happened this morning in Dr. Etienne's presentation. It just happened in my friend Amalia's presentation. So I'm going to put a little bit of a twist to it. I'm sitting here because most of my work in public health has been with community systems. Every time we discuss health for all, every time we have an emerging health problem, there is a big discussion about the engagement of the community and the people in this business. It becomes urgent because, of course, whatever the health situation is, it's going to affect the individual, and people need to be well, and people need to be cured, etc., etc. But as soon as the emergency is gone, health becomes something almost away from the community. You know, it's the hospital, it's the doctors, it's the nurses, and what is included for community is wait for the next crisis, or wait until you have your individual crisis and then show up in the health system. My discussion always, therefore, focuses on the social determinants of health. Where you're born, where you live, where you go to school, where you go to church, where you work, will impact upon your health. And you heard it said very, very eloquently by the director of PAHO. But I don't think that we do enough of a job in being clear that you have health systems, my friend Amalia, but you also have community systems that need to work together in order for there to be universal access to health. Half of the time, we are not getting people to pay attention to their health because we've set up our health system in such a way that we'll wait for you to get sick and then come, we will fix you up. There's a conspiracy against my soft del tones. Our contention, therefore, and this became very, very evident when we attempted to address the issue of HIV in the region, that everything that was happening in health in a response to HIV was going very, very slowly, if not what many of the community will call nowhere, because the community was nowhere in the discussion. And so for me, universal access, Eddie, really involves many more players to address many more of those social determinants of health than is presently done in the system. So my discussion is going to center around that as we agree to disagree.
Thank you very much.
Take it off.
Am I? that somewhere out there you have to go and get health covered, or that is in the hospital or the health center, that health is available to you. Now, WHO, which is a great organization because it really is composed of all of our nations, and the Director General of WHO made two very, very significant statements. One was that poverty is the greatest cause of ill health. I would never forget that. Poverty. She also said that the indicator of a health system status is really infant mortality and maternal mortality. Two very, very powerful statements. What am I getting at? We have to understand also what, in fact, WHO has said, and most of us has taken on board, that the health system is composed of three parts. The administrators and the people like PAHO, the healthcare professionals, doctors, nurses, and those who look after us, and the community. What is happening here when we speak of the health for all is that we have forgotten the most important part, the community. And sometimes individuals will ask you a question and it brings it home. Someone asked me, so tell me, what is my role in this universal health coverage? This is an ordinary person. And if you look through the entire strategy or whatever it is, that has not been enunciated. And I put it to you that we will not be able to cover or provide access unless people understand what their roles are. If we feel that people's role is to just access the health services, then they will present to the health services all the morbidity that they have. So one of the roles critically in this universal discussion and the health for all discussion is the responsibility of people, whether rich, poor, different or indifferent, to make sure that you approach the health system in the best health that you can, so as to reduce what the services has to respond. Because we must always remember something, that the determinants of health says this: health services can help you 40% of the way, but that's about it. The rest of it belongs elsewhere in terms of finance, education, and all those other things. So I want to make sure that in the question of this universal health coverage, that we really understand it is a journey towards what I like to say, health for all. So that, and we especially tell people what are their responsibilities in this health for all approach. One, to make sure that you are presenting yourself in the best possible health, and health is a positive thing, not illness. And two, you have to pay for it. And therein, I will stop for now.
Thank you. Thank you very much, Anton, Claudette, Amalia. We had really, I was expecting a little more conflict between Anton and Claudette. But the point is they both agree about the focusing on the missing link, the community, in the triad of administrators, workers, and community. We also heard from Amalia that, in fact, there is no distinction between universal access and universal health coverage. In fact, they're rolled into something called universal health. But what I want to do before I ask them to deal with the round of issues that came up in their discussions is to identify for you a very critical component of this Sustainable Development Goals targets. A very important target that will concern all of us, and to which Anton referred just now when he spoke about the range of diseases, was this. By 2030, the proposal is to end the epidemic of AIDS, tuberculosis, malaria, and neglected tropical diseases, and combat hepatitis, waterborne diseases, and other communicable diseases. That is the aim, that we do that. But to do that, we must have either health coverage, access to health, universal access to health care, or universal health, or involve the community. We must do all the things that the panelists in their opening statements said. But I want to just, before asking them the questions, throw out to you, the audience, something that has happened within the AIDS response, which might be a really useful model. UNAIDS last year came up with the thing to say, if we are going to end the epidemic by 2030, we must have something called the 90-90-90 targets. That by 2020, according to their science, we must have 90% of those with AIDS, 90% of people with AIDS tested, 90% of those tested on treatment, and 90% of those on treatment with viral loads low enough so as not to transmit the disease. Now that is a clear kind of target on treatment, prevention, and so on. That is a good model when we are talking about universal coverage and trying to answer Anton's question that we could keep in mind. But I just throw that out as something that is close to my heart and something that I advocate for almost on a daily basis. Now, with that in mind, I want to ask the panel if they might want to address some issues that came up. One issue that came up was this one, and Amalia raised it, and I want to explore it a little further. What can this region do to facilitate access to affordable medicines? What can this region do? But there's a complementary question. Is access to affordable medicines a human right? Have we taken steps in the Caribbean to achieve this human rights? What's to be done? And I think for Anton in particular, I wonder if he would really venture into dealing with how we handle the negotiations, especially the flexibility of the TRIPS agreement at the WTO, which all our leaders are asking for. Let us not be bogged down by the World Bank's classification that in this region, we are a region of middle-income countries and therefore not eligible for concessional fund. How can we tackle that in negotiating theaters like the TRIPS at the WTO? Now, it's the question really of rights, human rights, and people's rights and entitlement, and the issue of equity. Who will go first?
I can go first. I was hoping that we were going to be in total contradiction, but I think actually there is a lot of alignment. I think clearly, if we say that health is a fundamental human right, then access to affordable medicines is part of it. I think we cannot, in the context of universal health, we cannot talk about universal access to medicines and health technologies in the absence of the whole package. And because it's universal access to a comprehensive set of services that will require medicines and technologies, that will require infrastructure, that will require health workers, and the full package. So yes, medicines and technologies is a part of that and is considered part of a human right. Now, specific interventions to really avoid that countries will be looking at specific things without a holistic approach really has worked in many countries is when countries take the step to define very explicitly what is the set of guarantee benefits or services that the population is entitled, and that is going to be applied across the board regardless the ability to contribute, and I do agree that people need to pay, but what we are saying is, if you cannot pay, you should not be denied services. That is why it's a human right. So the solidarity component says that people contribute according to their possibility and receive services according to their needs. And I will stop there to generate more discussion.
I just want to make sure we understand when we talk about the ability to pay. But to answer your question about whether access to medication should be a right, we need to be careful that what period of time we are speaking of, because the question of pharmaceuticals and the ability of pharmaceuticals today and the technologies that are being put forward, the kinds of pharmaceuticals and drugs that they are looking to produce to cure people that could not have been done before and target you in terms of sending the drug direct to the tumor, et cetera, which will become basic drugs in the future, the cost will be prohibitive. So even the cancer medications we have now, which, you know, some people would say, and they're asking their governments, and then we can get into some of these things about whether it's a basic right. One of the biggest costs when I was in the Ministry of Health for cancer medications was costing about almost 30%, just the cancer medications for Trinidad and Tobago of the drug budget. And those were just, some of them just palliative. But you cannot tell a cancer patient who cannot afford that you will not buy a drug for them that comes at $20,000 a vial. But that is the name of what you are facing. And the new medications, which will become basic medications in the future, will be even more expensive. And I refer you to the question of MRIs and CAT scans. MRIs and CAT scans are now seen as basic tools in the health system. When they first started, an X-ray was the basic tool. Now everybody wants to get an MRI, $5,000, $10,000. So we need to be a little careful when we speak of things being a basic right and you have not understood the cost. Now the cost, when I said that you have to pay, there are different ways that we have to pay. What we must make sure our population understand is that in putting forward the question of your right to health services, it costs. Now, you can either pay it through increased taxation, which you have to pay, through insurance premiums, which you have to pay, or your VAT, or whatever it is, if you're going to go with a prepaid system, which is the most effective. But we cannot continue to suggest to the Caribbean people, which we're having great difficulty in that, saying that the government will pick up your costs when you are not contributing to those government coffers. The Caribbean health system has been built on the government health system. Basically, that has been going on for years, and we have done well in terms of the immunizations and the child care, et cetera, We are now faced with things like chronic diseases. And just to make one reference point to what you brought up, Dr. Greene, those targets they put forward in the UN for 20, 30 years from now, they really do not speak to us. Our issues really would be violence, mental health, chronic diseases. So we solving the problem of tuberculosis does not help us in terms of tackling what our problems will be. Mental health is a major, major problem in the Caribbean. Violence and trauma, which is being perpetrated on our young people, and they are all preventable. That is what is causing our problem in the emergency services and all the disabilities, and of course, the chronic diseases. And in order to deal with chronic diseases, we have to deal with the youth, exercise, diet, alcohol restrictions, etc., etc. Otherwise, we will not be able to afford that package.
This is a good place for Claudette to come in, a very good place as a psychologist.
Whenever I'm around Anton, we always start off sounding as if we agree. And, and then this thing takes over. When you begin to address the cost of health, I was thinking about the audience, saying, boy, I'm, you know, students over there, they haven't even started the insurance business yet, you know. They're still in school, and you virtually put on them a concept that they can't afford health. They won't be able to afford health by the time they get out of school and they get to university and they study, because the discussion is overly centered on these numbers. I'm so glad, Prof, you left the, what did you call it last night? The econometrics?
Econometrics.
The metrics. I'm just at the end. Because we keep putting ourselves in situations where we're looking at the end and never at the beginning or addressing the issues in the middle. The issues in the middle are very important issues. The issues around what we eating, where we going, what we telling people in schools. You know, there's a little discussion going on with the new Minister of Education about a certain thing that we've been struggling with for 25 years. You know, Eddie. All of those things are determining health. All of those things are determining development. But whenever I sit down with Anton, he starts to tell me about cost. And my contention is, if you do not have us participate, if you don't tell us how to stay healthy, if you do not tell us how to be communities that we live together in better relationships, you've got streets in parts of our country saying, you can't come over here. You know, if you come over here, we're going to tell you over here. Walk over so by your friends. All of those things are health and development issues. And they're not rooted in MRIs, in all of that stuff, because you're making us terribly unhealthy all along the way so that you have to get an MRI for us. We need to know, those guys over there, handsome young fellas, they need to know about how to keep their health, not how to become sick so they can visit your health facilities. I know Wayne is waiting very patiently up there for the open discussion. Let me put it to you this way. This morning I had for breakfast. Could I discuss my breakfast with you?
Please.
This morning I had for breakfast, my fruit was soursop from my yard. Yeah? I didn't have any kiwi, this, that, and the other thing that you're importing for all kinds of money. My thought was, well, if everybody can have a fruit tree in their yard, they will contribute to their health. They're going to reduce the metrics, the import metrics, and probably be better off than having to eat food that came from somewhere that already started to spoil when it got to the market. I took a walk. I took a walk with my neighbor. We are producing housing arrangements where people are not relating to their neighbors. All the women in my neighborhood, when I was born, everybody in my neighborhood, all the women in my neighborhood have a child my age. Apparently they used to do the thing They used to talk and plan how to do the thing. They all got pregnant at the same time. They all supported each other going to the health clinic. And when you couldn't go, they were prepared to bring home whatever the information or whatever it was that you needed to get from the health service. We don't do those things. And we don't do those things, I believe, because Dr. Etienne said it very nicely this morning. We all want to be specialists. We all want to specialize in our area. We all want to be the only one in it. And then the rest of the community is sick and down. So he and I don't really agree, you know. We do.
Well, this is getting interesting now because I disagree with both. I mean, agree and disagree. Why agree to disagree and then agree? Because if we talk about universal health and health for all, then it's not polarizing between community systems and health systems. It is equally important to build health and to strengthen communities and to address social determinants of health than having health services that are of quality and efficient. I think I want to also disagree that the cost of medicines should be the driving force to determine what we include or not in the package of services, because, for example, we know that all of that is driven by industry and market. When the first medication for HIV was developed, it was prohibited. And now we have generic medicines that really make HIV treatment really affordable. So we also need to think about what is the cost of not incorporating new technologies and new medication into the health services. Now the question is how we do it and how we deal, and that brings me to the point that I think we have not mentioned enough. What is the need to strengthen the National Health Authority capacity to regulate, to enforce rational use, to make sure that every decision that is taken to incorporate a new medication and new technology is based on sound assessments, and that then, therefore, we are not really compromising the access to basic services for all because we introduce one technology that perhaps may not be so effective because it's driven by the market and by the super specialists. That will agree, I will agree with Claudette. So basically, is the core. If we talk about universal access, we are talking about these two coming together. We are talking about moving in different ways of doing the business for health, different ways of building the business with the community. Is a balanced and holistic approach, and agree that it is not for this region, not only the Caribbean, but even in the rest of Latin America. We cannot only focus in communicable diseases, and perhaps, I think in the SDG targets, you will look outside of the goal 3, many of the issues that are related to that, because will be in other goals like equality, like fighting poverty, like education, like labor, like a safe environment that is really are dealing with those social determinants that then will facilitate that the goal 3, which is the health-specific goal, will be a reality.
Thank you. Minutes left for this segment before we throw the floor open. So this is a quick one. I wanted them, except in your last penultimate sentence, in your you mentioned something which is of great importance. In the 2030 SDGs, they placed a lot of emphasis on the issue of the health of women, adolescents, and children, and the access required to health as an important aspect of development. They place a lot of emphasis, and that is across about 5 or 6 goals in sustainable development. They've placed a lot of emphasis on women, children, and adolescents. I wonder who will make a connection between how we treat with that particular set of issues in the context of the universal access that we were talking about, or health coverage. It's just something I want to ask you to comment on before we go to the floor. But it has to be brief.
I'm often not brief. I want to make the point, though, Eddie, that we seem to feel we deal with health from the Ministry of Health in a kind of narrow confine. And that placing of health issues in areas outside of health, the Ministry of Health, so to speak, or the health services, is a critical part of how we achieve universal access. If we leave it simply to the health system, it doesn't work. You reference security. I reference it as well. You reference nutrition issues. You reference maternal child health. That is a critical issue. My reference state was with school health, what I call school health and security. Our young people are in school, they're not healthy, and they're not secure. Just look at Facebook videos that they're putting out about themselves, and you see it. And so it is critical. If we are going to change that paradigm, we must get to the place of women and children, fellas not making that much impact on, you know, family life that we would like, but women and children determine where the society goes in the future. And if we do not intervene there, I think we have some problems.
Thank you. Well,
I think that we are making a fundamental. Yes, I think that we're making a fundamental mistake if we do not bring men into that discussion. They always accuse the men of not being part of the family, but then you do not make any arrangements for them to take part in the family. And I just wanted to make the point. I wanted to make the point in maternal care. They ban men from the maternity department. It is your child, but for some reason, and then the question of a man's clinic is a recent introduction as a concept into the health services. The entire health services are really built along women and females and children and what and what. We are making a major error if we do not include that whole family input and take the men on board, because especially when I go back to that point about the mental illness. We have no idea what we are doing when we do not engage our young boys and young males with respect to that mental illness and what I call cohesion with the society and making a positive contribution and being part of it. Because when a symptom of that is the violence that young people, males, respond to women, because they are out of the discussion. We need to bring them into the discussion very early. Good. But I just want to correct one little point about the question of the cost. I'm not saying, if you thought that was what I was saying, that we are speaking to the question of we talking about the health services and cost. What we are saying is that you cannot expand or deepen even health promotion, even prevention, if you do not understand the cost implications of running the program. That's the point we want to make. Because in the Caribbean, we discuss health services. In fact, we build hospitals, we build health centers, we talk about health programs, and we do not speak to the cost. And most importantly, when we have an important issue to deal with, we look for help outside of the Caribbean and say, please help me, because we ourselves are not taking the responsibility for costs. The example of that, and Professor Ted also makes this point, HIV/AIDS. We have to wait until external help comes to say, I will help you with what in fact are your internal problems. So part of the development of the whole health system and the responsibility of people taking responsibility for their health is also taking responsibility for the cost of the things that you would like, whether it's prevention. It is that. It is important because there are two things in the health system in the Caribbean that is not there. The question of the cost when we discuss health is not there, and the quality of health services. We do not speak to those things. And therefore, if we do not bring them into the discussion about when we talk about health services, even promotion, prevention, whatever, what these costs are and what are the quality of services, we will always be deficient when we look at our neighbors from Europe and North America. We have to take responsibility for it.
In terms of equity, I must allow Amalia a minute. And then
Agree with that last part, and also agree with you about the need to really incorporate men into this. I think there are two different goals in the SDGs that will make that balance. Because one is the goal about women, children, and adolescents, and the other one is the one related to gender equality. Because when we talk about gender equality, then we are saying we need, and especially in the context of universal health, that we need to respond to the specific and differentiated needs of men and women. Because the men of today are the children in the past, and the adolescents. And the one thing that I will disagree is that we don't need to call them. They need to come up front. That I will disagree. We need, yes, to have systems that can facilitate the incorporation of men, but outside of that, definitely men can be more proactive in engaging in this.
Now we have heard some contentious issues, but we started off with the basic thing about, is it my thing? Oh, sorry. We started off about the distinction between access to health services and universal health care. I wouldn't go into all of that, but I want you now to join the debate. And I will recognize, yes. Second, third, fourth, fifth. Okay, we're taking 5 at the moment. Oh, which? Oh, okay. You have to go to the mics? Okay. Please, Dr. Yeah. The mic is working?
All right. Good day, everybody. People on this panel are aware that there are many things that were raised here that are, of which I'm deeply passionate. I think we need to get our terminology very clear. When we're talking about universal access to health and universal access to health care, our terminology determines our mindset. Most of us don't need access to health. We're born with it. We don't have to access it anywhere. What we need is protection from the things that threaten to remove our health. And we're talking about paying to get our health back. But every time I go to the supermarket, I'm paying to get ill because you are allowing the farmers to grow my food with poison. You are allowing the farmers to buy genetically modified seeds so that they can grow my food with even more poison. And you are allowing unhealthy, unpronounceable ingredients to be sold in my food in the supermarket. And at the end of the day, the pharmaceutical industry on the other side, I mean, I'm talking about what I consider conspiracy between the food industry that is making us ill and the pharmaceutical industry that's not fundamentally designed to help us get better, but to help us continue to take more drugs. Because when you look at the television, they want you to be no longer concerned about why you have a headache or a backache or you can't sleep. They have a pill for that. And even though the side effects may be worse than the thing that you're trying to treat, it doesn't matter. Right? They're quite comfortable to have you take all of these things. We also train our new medical graduates with the attitude that it is no longer important to help the patient discover what is the fundamental cause of their illness. They are quite happy to find the first drug that will treat the symptoms and allow them to go home. And these are trends that are disturbing to me. I agree with you, Claudette. It's not health services. These are illness services. They only begin when people are already sick. And at the end of the day, we have to make a balance between the interventions that are designed to help people who are already in a situation. But we need a lot more focus on preventing the things. And that resides outside of our health or traditional health industry. You have to regulate what is sold in the supermarket. You have to regulate what the farmers are doing and putting in the food. You have to regulate the things that impact on my health that are outside of the traditional mindset of the health system, which is not really a health system. It's an illness system.
Thank you.
I don't know what order you're going in, but I could just piggyback on one of the points that Wayne just made. First, thank you very much to the panelists, to the armchair discussants. You have raised all the issues that we need to deal with urgently in the health system if we are in fact to improve the health of the population. But as I listened to what you're saying, 3 things came up in my mind, sort of threading through. One is definitions, and that's somewhat to what Wayne just spoke to. We got to make this thing clear. If health is outside of the Ministry of Health and the health sector, we better get some simple language that other people can understand. What is the difference between health and healthcare? This was a question that was, and healthcare services worse. This was a question that was asked to me thousands of times by diplomats when they were trying to, in fact, promote our interests in terms of entities at the UN. What do we mean? So if we have to get it simplified so we can explain it to the community so they can understand it and then they could tell us what they want out of it, in fact, if any of it at all. So I urge that we begin to get health versus healthcare very clear. We begin to get what is the right, health or the conditions for health? If you're going to market what you want, what is the right, health or conditions for health? Because that throws a completely different picture and people begin to see themselves outside of the health sector rather than just health is a right. So health is a right is something that we in the health sector understand. It's a vision, it's a concept, it's a human right, it's there in the declarations of the UN. But in terms of getting the community, the society on board, consider that it is the health conditions we want people to focus on, and the health conditions for health, are outside of the health sector. And that's when people begin to say, oh, as you hear them. The second thing is consensus. Having defined all of this, I take the point that Claudette is making. We need to bring in the community, and we need to bring in the community in the agreements as to what we want. I mean, although we say it's outside of the health sector, I still keep hearing the health sector sets the target, sets the definition, sets the plan. And we've been doing this for too long without the community participating. At the beginning of Health for All, I don't know if Anton will remember, there was a national consultation in which countries, in this case it was a huge consultation, decided that what did Health for All mean for Trinidad and Tobago? And I think we need to involve in a very large consultation that kind of discussion for us to really think and make the community think that they're participating in the decision making as they go forward. And the third thing was the community participation. The community participation was one of the weakest components of the Health for All strategy when it was evaluated some 20 to 25 years after Alma Ata. It continues to be something that really challenges us in the health sector because by definition, doctors control. We know what is good for people. And so it's a completely different paradigm that we need to get to and must come through, especially training of the professionals that have to work with the community in the health centers. And I just bring to remind us that, in fact, when we're talking about NCDs, we talk about the whole of government and the whole of society approach. And this was nothing new. We talked about this for a lot, and we talked about it in the health sector as if it were, in fact, something coming up with NCDs. Lo and behold, nobody in the health sector knew that whole of government was, in fact, the strategy for implementing the last medium-term framework. So we in the health sector had separated ourselves, as we often do, from the rest of the development sectors. And we were not part of that development process, and literally missed an opportunity to get much more than we did by just thinking of it as any specific health problems. So I urge that the definitions, the consensus, and then finding ways for community to participate. HIV program, Eddie knows, with the national commissions, was one of the ways that it was done. And I think Trinidad has a bit of experience that shows people it is critical. When you didn't have it, when you let it drop, your program dropped. The community became complacent. And so we need to, in fact, build on those experiences as we go forward.
We have to go to, that's third, then you.
Thank you very much. I'm glad, Eddie, that you brought the example of the 1990, because it does, in fact, speak to us for two reasons. One is that we still need to deal with HIV as one of the priorities among the others that have been mentioned, but also because there are global targets to which we need to contribute from the Caribbean and from Trinidad, of course. And they are part of targets that include also the reduction of new infections with HIV and zero discrimination, which in fact should be on the top of these three priorities, which really speak to the role of the communities. And in all of these priorities, whether it is about zero discrimination, access to services, and prevention, the role of the community is essential. What, Claudette, I think we still need to figure out is what exactly the community is doing with the institution, with the healthcare systems. What are the strategies? What do we do to strengthen each other? The community needs the institution to advocate, sometimes to do some activism. But this is important, but is not enough. And then, therefore, they need the institution to understand what is the strategy to move forward. At the same time, the institution also needs the community to make sure that the services are provided according to the needs, and also because the community can also provide services in many ways, including healthcare services.
Thank you. Thank you.
Okay, thank you very much. The thing is that I don't want to be like Claudette. Everybody tells me I talk a lot.
We're not hearing
So
you.
I'll try. Oh, sorry. Yeah, I don't want to be like Claudette. Everybody tells me I talk a lot. So I'll try to sort of shorten what I have to say as much as possible. I think the one that I'll put on top is the question of gender. Now, I have called the television station, and tomorrow I'm going to Express to get them to remove the ad that where the lady says she's going to get a maxi.
We're not hearing.
I call them.
We're not hearing properly.
Oh,
Yeah.
sorry.
Yes.
Okay, what I'm saying is that the first thing I'm going to talk about is gender, and I've called the Express and TV6 and asked them to remove the ad where the lady is telling the gentleman that she's going to take the maxi. That woman was so abusive to that man. I am saying there, that is the normal behavior that we have. And if it was me, I would not have been in that house. I'd gone a long time ago. So what we are saying is, how do we socialize how do we socialize as men and women and family in this country in terms of the gender relationship? And this is one of the major areas, I believe, that has to be addressed with regard to the male and female relationship. And maybe in that way, we'd find more men remaining in the house, because if that lady was talking to me, I'd gone a long time ago. The other area is cost benefit. Now, in Trinidad and Tobago, you asked about cost benefit. I was trying to compare the education of someone from early childhood to UE with the cost of providing antiretrovirals. No one could give me the cost of educating a child from early childhood to UE. So this is one of the areas I believe that we need to look at to ensure that we are able to manage the cost of these things. The other area is prevention. I believe that prevention and preventive mechanisms are so important. And one of the areas that I really have a problem with is the HIV agency. The question is, why do we have a temporary agency? I brought up this in an African country and said, listen, we need not to have an HIV agency. And the question here is, with malaria, we were able to get rid of malaria by having the department or the unit that did the spraying. When mealybug came, we used the same department. When chickpea came, we used the same department. If we had such an department in places like Liberia, instead of temporary agencies, when Ebola came, the system would have been in place to be able to handle Ebola at a very earlier stage. The other point is aging. We are giving the aging all kinds of pension benefits, but their dental problem is there. The question is, can they eat the food because their teeth, they have problems with their teeth. And the cost of dental in Trinidad and Tobago is very high. So this is one of the areas I believe we need to look at. In terms of HIV and the three 90s. Okay, our measurement system, our monitoring evaluation system in Trinidad and Tobago is non-existent. So therefore, how can we manage an epidemic like the HIV when we do not have proper monitoring and evaluation? And as I talk about that, I want to talk about leadership. The leadership with regard to HIV in Trinidad and Tobago is sadly lacking. And also, at the UN, how could CDB and Piot and these guys sit there, the lady from Malawi, all doctors, sit there, and the Lancet then says they are surprised that HIV has increased. When we had situations like Southern Sudan, Darfur, the Arab Spring, we had situations like the Congo, and then we say we do not know migration is a cause of HIV infections. So the question here is that how do we put in place the indicators and manage these situations? The other areas I want to go into, I would not be able to go into, but basically the selection of leadership, as Dr. Sankat said this morning, there has to be a greater point with regard to management studies in the leadership in these areas. Thank you.
Thank you. Thank you, and good morning. And
now, I just...
Certainly. Right. All right. While this is the conference on the economy, I focus in more on Trinidad. I'm from Grenada, here to support my brother, who I've been working with for 20 plus years. And the issues raised are so relevant, not just to Trinidad, but to the rest of the region. I want to somehow ask you, though, what do you see the role of alternative medicine, especially things like yoga, that is now proving to be very therapeutic in terms of prevention? What do you see the role of alternative medicine? And I will ask you this one also. What do you see the global trend of medicinal marijuana? And how do you see us using that as an economic issue?
Can you hear me? All right, yes. Dr. Anton mentioned, he singled out a few issues, and he mentioned mental health, community, the involvement of the community, and men. I would like to add another one, the whole issue of sexual and reproductive health, because I often wonder if this is given as much attention as it should. Recently, I did a consultancy where I had to look at these services in some government health centers, and I found three things. One was that there was a wide disparity among health centers about the level of service provided. Another one was there seemed to be a lack of training. For example, a young woman came in to talk to the nurse, and her only response to her was BBB, the three Bs. Boys, books, and babies don't mix. Any of us who can cast our minds back to when we were 16 and 17 or 18, tell me if you would go back to that health center. So it was accessible. Was it accessible? Was it available? Another young man came in during his lunch hour to get some condoms. They made that young man sit there for more than an hour, name, ID card, a whole lot of nonsense, just to give him a few condoms. The third thing is the lack of consistent availability of commodities, so that the woman goes to the health center or the man goes to the health center 1 month, certain contraceptive commodities are available. Another month, the pap smear reagents are not available, and so on. So I just wanted to bring that whole thing to our attention and to ask the question whether the issue of sexual and reproductive health is paid enough attention, whether the training is given to the health providers, and so on. Thank you.
Thank you, and I just wish to okay, right. I want to commend all the presenters this morning, and there was a common thread that ran through all of their presentations, and that is the need to focus on the fundamental conditions for health or the social determinants of health, and WHO has already identified the framework for that, which is the health in all policies approach. What is needed now here in Trinidad and Tobago is to implement it. And in order to do that, we need to have a national coordinating body for that, interministerial in nature, and that will have representatives focusing on every sector, education, on agriculture, and there are simple things that can be done. As a matter of fact, the health in all policies approach that WHO identified, and we contributed to here in the Caribbean, they have already identified role for sectors. So we don't have to reinvent the wheel. We just need to have the political will, and we need to get it going fast.
One minute, yes. Thanks to the panelists for your presentations. They were extremely enlightening. Just a few things I wanted to kind of touch on. I'm sorry? Yeah, okay. Just in terms of when we consider the ecosystem of health, and we discussed that health at various levels, looking at the individual, community, the familial level, the societal level, and we are becoming very microscopic and myopic in how we consider health. And then at the individual level, when we think of health, the first thing I learned when I did my MPH at SGU was that health is not just physical well-being, it's emotional, mental, societal, all those components that we are missing. And Dr. Cumberbatch, you touched on it, the issue of mental health as a critical aspect and how we're looking at trauma, crime and violence, etc. And then also looking at health across the life cycle, which it's unfortunate, I think we're not having that discussion more. The role of children, not just as beneficiaries, but contributors as well, in terms of how they conceptualize health and what that means when we're looking at chronic diseases, lifestyle diseases, etc., which is something that PSI, the organization that I represent, looks critically at. So I would kind of implore us to look at two areas where there is entry points: the workplace, where we have the productive and the reproductive sector, very critical. Most of us spend half of our lives at work, and we could really make entry points when we're looking at private-public partnerships, and the schools as well, and the value that young persons place, and that can contribute as well.
Thank you, Dr. Greene. Hello, Anton. Hello, Eddie. Hello, Claudette. Hello, representative from PAHO. The topics that have been broached this morning and this afternoon are all being broached on the global and regional agenda. PAHO meetings, WHO meetings, CARICOM meetings, these are all crucial, very crucial and very relevant and timely topics. So congrats to you, Vito, for hosting this very, very important session. Regarding the social determinants of health, the ministry has taken it on board. The second to last speaker. In 2011, we attended the Rio Conference on Social Determinants of Health. We came back saying that this is Trinidad and Tobago, that this is something that we should focus on the national level. All right, there was a cabinet subcommittee made up of about 30 ministries, UNDP, PAHO, Trinidad and Tobago Manufacturers Association, Chamber of Commerce, and there's a national action plan that's being considered right now, all right, for implementation to address the social determinants of health. So this will be rolled out eventually. Regarding UHC though, Dr. Cumberbatch, Claudette, I noticed your very lively discussion. I think, when you discuss universal health care, I think it needs to be built in a sustainable framework, especially as, according to the Commonwealth Secretariat, there was some information that was published, that was released this year. In 5 years, persons over 60 years will outnumber children under 5 globally. All right, what are the skills of the future that will be needed? All right, in terms of actually financing healthcare, Dr. Cumberbatch, I have a question for you. How do we move forward? Do you agree with taxation versus capitation? Because it's something that the Ministry of Health is looking to reintroduce or restart. How do we actually pay for health? It needs, and with regard to the fact that it needs to be built in a sustainable framework. How do you, if you're back as CMO, how would you help to lead that discussion?
And therefore, I want to thank David Constant for that last set of comments and a question. And I believe that we have to say to him, please engage Dr. Cumberbatch in his capacity as senior fellow at the Center for Health Economics. Okay? Because I think that's where we have to start the work. And the Prime Minister last night did say that he must engage this center much more, therefore. So I think that you need to carry out that mission the Prime Minister indicated last night. But I just want the panelists to take 1 minute each for any takeaways that they want us to remember as we leave here. And it must be 1 minute because the organizers are breathing down my back.
Yes, I just want to make 2 comments. One, yes, two comments. The health determinants and policies, health and all policies. In fact, the committee for that is a place and a committee called the Cabinet. It's already there. That's where it is done. New Zealand has a model, and that is where it is done, and we suggest that. The other comment I would make about community involvement, one word, cell phone. Everybody has a cell phone. You want to talk to people, especially the young people, use the cell phone. That is the modern way of communication, and that is the way we can get people involved with information.
I want to respond. I have to fix my business with the fellas. All of my colleagues know that I'm a big flirt. So if there are young men in the room who weren't too happy with me leaving them out of my health paradigm, I have to fix up with you guys. Now, but I want to make the point about the issue of men's health as an important takeaway. Men's health is nowhere in our system, really, and it really has to do with the fact that we do not have a strong enough adolescent health program that would really engage young men at the time when you can have the greatest impact for their prevention behavior. So fellas, I'm advocating for you. In terms of Karen's point about the community systems being the weakest systems, I don't think they are weak. I think they are not valued. It's a totally different thing. The community has been participating in health in all kinds of ways from the time I knew myself. The thing is, are they valued as partners in the dynamic? And that is where we have to work. Then finally, Michelle's point about the community as an advocate, as service provider, and as watchdog. I think it's very important that if we understand that the community plays those three roles, it is easy for how we should engage the community. But if we do not value the community in that triad, you will never get, you could use as many channels as you want, unless you put in a good fight on Facebook, you're not going to engage the community because they still have the strategy for sifting that out. And finally, my friend Kennedy, I'm a mental health professional. For many, many years, I worked in mental health and I saw the impact of drugs of varying kinds. My entire program started in cocaine abuse. I have a lot of ambivalence about a discussion about medicinal marijuana, especially in an environment where you haven't engaged the community at all in a discussion, and then somebody planning about medicinal marijuana. If I was a marijuana smoker, like somebody a few weeks ago said, I don't smoke ganja, okay? But if I was a marijuana smoker, I sick one time because I could simply use the idea of it being for medicinal purpose to encourage a behavior that may not be the best behavior for me. Yes?
Yes, thank you.
Thank you. Oh, let me turn this on.
Yes, I think I see a lot of agreement and consensus, I think, in the what and the values. The challenge is the how, and what are some of the strategic interventions that can help us to move forward, because again, we are not really starting from scratch. And I want to take one intervention that I think from the health system perspective is critical, and that is the change in paradigm in the way we plan and we manage the definition of targets and priorities. If we will go by defining targets in a vertical manner for different diseases, we will not get there. I'm sorry, I'm coming from HIV. For many years, we will not get there. For us to advance, and if we look at universal health as the vision, then our planning paradigm needs to include that there should be a process of definition of national goals and targets that respond to the needs of a given country, with priorities that need to respond to the issues affecting health in that given country. Cannot be a disease-by-disease approach, and most importantly, it needs to be inclusive. It does need a whole of society approach, and also need mechanisms for accountability, monitoring, evaluation, and having the engagement of people and the communities in looking at how we move in those commitments, goals, and targets that have been defined is extremely important. So I will end there.
Well, ladies and gentlemen, I have no time for my takeaway, except that I want to say, if we are to move